calcium nodule, orbital secretary has much larger chance of ablating that also. It's very nicely showed by Dr. Quasi that it is very important to go slow. Otherwise, you would be just missing lesions. If you go fast like rotablation, you would be missing lesions in between, and you will not gain the lumen also. I'll just show two, three cases very briefly, and these are not very difficult cases, but just to give you a simple principle. So this is a 75-year-old male patient who had calcified LED stenosis. RP was normal, and when we passed the wire, then there was a debate that OCT may not, OCT may not cross these tight lesions, or you may have to dilate. But here, and or of course, if once the OCT has even crossed, it may not show imaging because the contrast clearance will not be there. So first thing is that as soon as you cross, once you are giving contrast, shift to the manual mode so that you can get some images. Otherwise, if you keep it on the automatic mode, the distal catheter will not will not read that the contrast clearance is there, and the OCT will not move. And by the time it starts to see, you've already completed your contrast injection. So it is very important to shift to manual mode, and then as soon as you inject, you take the full back. And then in this, there will be some blood, but then of course you would be able to diagnose. And you can see in this clearly that the OCT run that shows that there is this calcium is thick calcium, and there's a R which is more than 280 degrees. So orbital section was done, and as highlighted, we go at 80,000 speed first, and we go very slow, 1 to 2 millimeters per second speed, and we do multiple runs. So in rotablation, we've been tuned to see if there is no obstruction. There's no point in keep on doing rotablation again and again. While in orbital section, it is always good to do more runs, even if your run was smooth. The more runs you do, the more likely you are to clear the superficial calcium and also crack the deep calcium. These are multiple runs which we did, and then finally the OCT was done after that, and you can see that practically all the superficial calcium is gone, and the thick calcium is still there, but there are cracks there, and the balloon gets very easily inflated. This is just a non-compliant 312 millimeter balloon, which shows very good expansion, and then stent also shows very nice expansion. And the post-OCT run also shows a clear, stent expansion. Another 51-year-old female, she had critical LED lesion, the circumflex and RC were all right. There's a calcium in this patient, so angioplasty, and then of course the same thing, a critical lesion crossed by the OCT easily, and then to do it, you have to really do it on the manual mode so that you can see it, and then there's very tight 0.89 millimeter lumen, and then the order was done. Without any balloon dilatation, we could achieve very large lumen, and the OCT shows that the areas where the calcium got shaved and the lumen gain at that point is very good, just by orbital and without any ballooning. And then after ballooning, the lesion was very nicely expanding, and the stenting was done. There was some distal edge dissection, which was again stented with the another stent. So I would just forward that. Very simple procedure, nothing great about it. And this is the final result that we achieved after the stenting of the patient. Another patient, 69-year-old who had angiography in 2021, and there was not any critical lesion. You can see there is a dominant circumflex, which is all right. But then again, the patient came with drop positive, and now there was a filling defect at the ostium circumflex. The patient was treated at the outside center where they did the angiogram, and they thought this is thrombus, and they put the patient on left local conservative parent. And then patient came to us. We just checked it, whether it's still there or not. But then of course this is now the experience shows that it is most likely a calcified nodule which is showing like that. And this is clearly seen in the OCT run where in the first now it appeared that there is a calcified nodule at that point. So we did orbital mastectomy here. It was a large vessel, so we did 1.1 like 20,000 feet also, because it was a 4 millimeter vessel. And the post orbital is the OCT, and OCT shows that there is still the vessel lumen gain is there, but still there is a lot of work to do. So they then made IVL also 412 millimeter balloon, and then after IVL there's excellent result. And then OCT showed that the ostium is clear of disease, there's no dissection. So we just ended up with a DCB here and did not put a stent. And on follow-up, the patient is doing fine. Here is the OCT run which shows that there is a great result after that. Thank you.
Thank you, it's a wonderful case, a combination of the two tools in one. I'm not sure about the drug-coated balloon being used in large vessels, especially after doing so much work. What was the rationale?
My rationale was that this is a ostial circumflex lesion, and if we put a stent there, it is extremely likely that either the stent will miss the ostial circumflex or it will protrude to the left main, and then the patient will have a ping pong sort of a disease coming back with the LAD stenosis. So if we are sure on the OCT that there is no, we are not leaving any flap which is flow limiting. If we are not leaving a lesion and we are adequately achieving the MSA is there, not MSA but the lumen area is achieved, then probably putting the stent is not going to achieve anything further. And of course, this case was done 6 months back, so there's a lot of, we need more follow-up about it, but probably such large vessels use of directional effect in osteal circumflex lesions. And basically you're removing the atheroma, do a DEB and come out, because the chance of restenosis on a stent is that of is very high. So there is data coming from vitrectomy, directional vitrectomy followed by. So this was a great case. I mean, he did an orbital followed by IVL, what looks like a normal target, and then he puts a DEB. I think. Yeah, and just one thing I want to ask you. So, is it safe to say that a non-CTO heavily calcified lesion, the preference of imaging is OCT far more than fibers? So, both the modalities have their own advantages. If the patient creatinine is normal, if the ejection fraction is all right and TRAPS is not a problem, then the OCT gives far more information in calcified lesions at least than others. So yes, if the OCT does not have a contraindication, I would prefer OCT. Thank you. I think we have to close it. There is one announcement. I can ask you.
So the first case, China was also having a good size diagonal or still tight lesion cancer. So what happened to that? Of course, with this orbital we can open the diagonal also separately like rota.
We could, but then we just planned a keep it open strategy. It was flowing, so we did not treat. I need to make a small announcement. This session is closed. Courtesy, the session was Abbott session, so I think it was a well-balanced scientific session, points for and against the use of devices. So there is a small announcement to be made. 8:30 there is going to be a program in this hall. So I request you all to come back after please 8:30 tonight. Thank you.
हेलो शिवम अच्छा देखो शिवम आ रहा कि नहीं आ रहा है,